Hi, everybody. My name's Tonya Wheeler. I'm a woman in long-term recovery. And for me, that means I haven't used drugs or drank alcohol in over 29 years. Thanks. And so my primary drug of choice was methamphetamine, although I liked to drink a lot with it and smoke a lot of pot with it back then. And I was thinking about when I first got introduced to meth and how really innocently I fell into that lifestyle. I had never been around people who were using what a lot of us call hard drugs. You know, I had smoked pot and drank alcohol before. And when I was 18, I started working with this girl, and we were working overnight shifts. My parents owned a donut shop. How fun is that? And so we were the girls that at 2 a.m. were going, time to make the donuts. And so I had no idea. And she invited me out to her house one night before we went to work and started telling me about using methamphetamine and how wonderful it was and how it gave you all this energy and kept you awake. And I was one of those people who would say, I would have never imagined using drugs IV. And for whatever reason I was sharing in the previous session that I can't explain to you how this happened. But her and her husband were there. They were telling me that, if you did it any other way besides using it IV, that it was a waste, it wasn't as good, it wasn't as fun, and for whatever reason, I let my guard down. And so the first time I ever used meth, I used it IV. I would never use it any other way the whole time in my addiction. There's a lot of things about me that are like go big or go home, and I guess that was one of them. From the time I started using, I had 2 little girls, and from the time I started using, there was nothing else in my life that was more important to me than where the next high was going to come from. I had been raised by, my parents were married until my mom passed away. I had been raised in a very family-oriented environment, extended family, lots of big family. And so when I started using meth, it really took over everything. I wasn't able to parent. I wasn't able to work. I did nothing except chase that high. I think one of the hardest things for me personally to get over in regard to the guilt and the shame when I entered recovery was the fact that I had not been there for my kids. And I'm really grateful to say that I got into recovery when they were 5 and 1. So I had a lot of parenting time left. But there were a lot of barriers and a lot of things that we had to walk through and get over in order to become a functioning family again. My 5-year-old thought and really was allowed to think that she was the mom in the family. And I really operated as one of the children. And she took as good a care of me as she could. And she really parented her little sister who was 1. When I got into recovery and started to get better, one of our hardest obstacles was to switch that role back to allow me to be the mom. She's still very protective of her little sister. And, I had to face that stuff. And I had to realize that my behavior and my thinking during the time of my active addiction was about addiction. It wasn't about love or not loving them. They're 2 different things, and you can't compare those 2 things. And so meth took me down pretty quick. I used for 4 years. I was at the point where I believe I was close to dying. I was one of those females that loved the idea of losing weight using it. I loved the energy about it. I didn't really eat. I was not very good at sleeping. I was really good at staying awake and waiting on the next shipment to come in. And I was hanging with some pretty dangerous people in my life. So I don't know. My parents had taken me to treatment once when I was 18, and I agreed to go, but I didn't stay. I was only there 3 days. But I think that experience really gave me the opportunity to know that there was help out there if somebody was to reach out. And so I made my own phone call and went into the next treatment center. And I got to stay about 3 days again because they told me that my insurance wouldn't pay for me to be there and I had to leave. And I weighed 100 pounds, soaking wet. And I just remember my body and my brain, there was no Tonya left. It was just a shell. And I cried when they told me that and told them I was going to die. And so I moved along, and I went into my parents had moved away from my hometown, and they got me enrolled in an intensive outpatient program, and that's where I really found recovery. But I will tell you that when I went into treatment that last time, what I really believed is that meth was the problem, and smoking pot and drinking alcohol was not the issue at all. And that everybody just needed to leave me alone and let me do that because it was fine. And so I really, today I understand that what I was doing was using a harm reduction model to get myself into recovery and where I needed to be. And I'm really grateful for the opportunity to have been able to do that, because what it did for me was it showed me through my own experience that it was not one particular drug, that it was addiction. And this is not true necessarily for everybody, but for me, I used up my right to use drugs and alcohol. And so I was 22 years old when I entered recovery. I raised those 2 little girls with a lot of help from my family. Back in 1990, when I got into recovery, and I'm from a small town in East Texas, y'all couldn't tell, right? So back there, your choices were 12-step meetings. And so I'm real grateful to tell you that I got very involved, and that worked for me. I am still very involved. I believe that my recovery is something that I have to work on a daily basis, that it's not something that I can just pretend didn't happen, that I have to stay conscious that this is a disease and that it lives in my brain, and if I was to pick up again drugs or alcohol, it would be catastrophic. And so as a result of all of that, I'll fast forward real quick and tell you that I became a drug and alcohol counselor in Texas in 1997, and then I moved out to Colorado in 1999, and I got my CAC-3, and I worked primarily out here with women and pregnant women and women with children, which I loved because they're my tribe, right? And in 2001, an organization started to come together in Denver called Advocates for Recovery Colorado. And I came to the table like 2 months after they started talking about it. And here we are 18 years later. And we now provide, and I'm the director, and we provide peer recovery support services for free to the community. We don't do any clinical services. We're a recovery community organization, and so we're independent and we're peer run, and we're just there for people who want to connect. I'm a big believer that connection is the solution, that if we're going to find solutions to addiction, we have to help people get connected to people that are from their own tribe, but people who are in recovery and who are succeeding in life, and that is really how we make a difference. And so we're located over in Denver, and we do peer coaching, both individual and in group settings. We host what we call all recovery meetings, which means everybody's welcome. We support all pathways of recovery. We never tell people you don't fit here or you don't belong here. We believe that people are in recovery when they say they are, and we don't monitor that. And we believe that there are all these different pathways, and some people do 12-step, and some people go to church, and some people use medication, and some people don't do any of those things, but we are sort of the anchor that connects the community together. My goal is that we're going to have recovery community organizations all over the state, and especially in the rural areas, so that people will have a place to get connected to other people that are in recovery and that are like-minded. And I am going to hand the microphone to Wendi.
Very awkward for me to hold a microphone.
You can sit it on there.
It's fine. It's fine. Hi, everyone. My name is Wendi Hoag. I'm a therapist at Denver Health in the OMAT clinic.
I can't hear you.
Can they not hear me?
Maybe just closer.
Oh, closer. Can you hear me now? Oh, I can hear myself now. Thank you. Okay. So again, my name is Wendi Hoag. I'm a licensed professional counselor at Denver Health in the OMAT clinic. I've been there almost 2 years. Our focus is really helping clients build a life of recovery. It includes methadone or Suboxone treatment, individual therapy sessions, and even our groups are pretty extensive. One of the groups that we've held a couple times now is using contingency management to help clients who in particular struggle with methamphetamine use and dependence. The group has been overall really successful. So the group will be 12 members, co-ed. It's a closed group for 12 weeks. Clients have asked for it to be extended. So we've had 2 groups and we've been able to extend it by 2 to 4 weeks. The focus of the group is to educate clients about methamphetamine use, triggers, cravings. But I think for me, it's as a clinician, I always look at the person as a whole person. So we don't just talk about addiction. We talk about your family system. We talk about limits and boundaries and what your future goals are, right? Is that separate from the addiction? Who are you? Who do you want to be? How can we help you in this group to be that person? Or, what else can we help you with to I think, have increased self-esteem and confidence and be able to go out and feel like you're not your addiction. So contingency management is, we have 500 cards in a fishbowl. 250 are inspirational quotes. And the other ones are broken down between small, medium, and jumbo. Small is 10, medium is 25, and of course the jumbo, only one, is $100. So clients, when they attend each group, they get a pull for attendance. Every UA that they have that's negative for methamphetamine use, they get a pull for that. If they have a UA that's free of all substances, they get another pull. A special feature of this group is that the consecutive UAs for methamphetamines, clients can pull. So if we're in group 5 and someone comes in and they have 5 UAs that are negative for methamphetamines, they get 5 chances to pull from the fishbowl, 1 for attendance and another pull if they've had a negative UA for all substances. This, I think, for clients is very reinforcing, right? It's that positive reinforcement of this shows my recovery. So clients very much will attend the group. And I think it's also inspiring and reinforcing when they see maybe one client pull more times than they were able to pull. For example, this last group that I had, there was a client who had a relapse with methamphetamines, and in that situation, he had to start from the very beginning. But then when he came in the next week and he saw someone pull, say, 10 times because she had 10 UAs negative for methamphetamines, you could see in his response in his face, it's like, whoa, you were able to pull that many times because you maintained recovery. But then all the groups after that, he did not relapse. So he wanted to earn more of that positive reinforcement. And some of the group, and like half of the group is going to be content. I'm very focused on using activities and sheets, homework activities that the clients really responded to. So I use phototherapy, clay therapy, different handouts, kind of homework assignments of, you say this is your goal to work out and be healthy. So I need you to work on that. You're going to commit to it, and then we're going to talk about it next week. And then I would always make sure to follow up and say, hey, how did that work? And if the person didn't follow through, okay, so what happened? And can you commit to doing more exercise or decreasing smoking for the next week? So very much person-centered, whole person perspective, non-judgmental. And then our third group is actually going to start September 11th. So we're really excited about that. And we're also very hopeful that we can bring contingency management to the other groups that we have, because we have some really good groups, but attendance can be difficult. Sometimes we just won't have clients show. But with no more mething around, the group that I lead, we'll have 5-6 clients every single time. And then treatment retention after the group ends is exceptional. From the first group, I think there was one client who dropped out of services, and then the second one, I think 2 people left the program. So that is hopeful for us, right? That we get group attendance. We help clients access other members of the community. And usually by like group 5 or 6, you see a community between the group members, which is really good to see because they support one another, but they also challenge one another. And that I think they're more receptive to a peer challenging them, supporting them, than maybe a counselor would. So, but we're really excited to keep that going. Okay, thank you very much for listening.
Hi, I'm Jeremy Dubin. I'm a physician, family physician, and addiction medicine specialist. I've been doing this around here since 2005 is when I first got board certified in addiction medicine. And I am currently medical director of Front Range Clinic, which is an outpatient substance abuse clinic that has over 18 clinics up and down the Front Range, and currently I'm managing about 39 medical providers. And when I was asked to come here to talk a little bit with this great panel about diving into methamphetamine use, the first thing I said to Leslie was, well, there's no medicines for that. So what are we going to do? And she said, come on, tell us what you've been doing. And what we've been doing is I want to share some stuff with you as we move in here, and I'll say a little bit now. And I have some slides, but I think who here, show of hands, was at the methamphetamine talk just last, like a half hour ago? Okay, so half. We can jump into some slides if you got maybe. But I want to make sure that we're all on the same page, and I think some of the messaging is important that I think everyone has gotten today, and I think most of us that are at this conference are already understanding this piece, but I think it's an important piece to reinforce, which is that drugs and alcohol are not bad. We've been using drugs and alcohol for thousands of years. Coca leaf in South America, Rastafarians with marijuana, Judeo-Christian cultures with wine. We can keep going down the list. And it's not necessarily the drug, and I think what all of us are starting to see here with Dr. Waller's lecture earlier today is that it's the vulnerable individual. Drugs and alcohol work. And if they didn't kill us and potentially destroy our lives, then we would be prescribing them as doctors. Heroin works. Methamphetamines work. Marijuana works. Booze works. The trick is to try, and from the medical side at least, and I think we all share this, in now providing service and trying to help people go from a survival state to a healing or thriving state, is to meet them where they're at. And that's been the message where we've heard today, whether it's harm reduction, whether it's abstinence-based, whether it's medication-assisted treatment. What's the goal? And so I want to just quickly just have this 30-second kind of let's make sure we're all at the same bar. Because if we're really going to swallow the idea that there are biochemical changes that occur in somebody that has been having an addiction, not misuse, not occasional use, not recreational use, addiction, which goes beyond problem use, that there's actually brain changes that have occurred in these folks. Ignoring that is why we probably are in where we're at. And with these numbers we've seen, at least with opioids, and now we're seeing with methamphetamines. So we know that there's been changes that have been going on. Now, if we make that analogy, let's say with diabetes. So when someone comes into my office when I was doing family medicine and we were talking about their sugars, I could do a blood test, and hemoglobin A1C, a blood test that tells me what is predicted as far as their risk of having a heart attack, stroke, blindness, losing limbs. And we use that as a gauge to help with treatments. And I think some of the messaging that we're getting today that I hope people are going home with is that we don't have the best tests yet. We don't have that test to say, well, you're 20% genetics, 40% trauma, and 40% crappy friends. Do you know what I mean? We don't have that yet. So until we have that, we got to do anything and everything to help these folks first survive and then create strategies for healing. So when it comes to methamphetamines, it's tough, right? Because in medicine, we don't have a medicine yet, like we have, for instance, with buprenorphine for opioids. We don't have something that actually speaks to that biochemical craving, that potential injury. So what we do have is we have studies based, and I have some of these slides, but if it's okay, I'm just going to kind of talk. If I can jump in if someone gives me the heads up to not do that. What we do have is we have studies from the 80s on cocaine, to be straight. We have some stuff on methamphetamines, but it's mostly from the 80s and cocaine. And what we have is that it's behavioral intervention, contingency management, what's called the matrix model, which includes contingency management, cognitive behavioral therapy, DBT, and some other issues, some other modalities. And it works if you get into it, if you have the resources, if you're lucky enough to get in there. And as many of us in this audience can say, and us up here on this panel, sometimes you don't have that. We don't have those resources. Or someone's homeless. Or they have co-occurring mental health issues that make it that they can't get there, or insurance issues, or spouse issues, or transportation issues. And so it's easy to say, well, this is what's going to work for you, but I can't give it to you. So in medicine, you know, we're the science geeks in the audience can speak to this. You know, we always want to say, well, what's the biochemistry? You know, where can we change some things? Where can we plant a seed to help, as we say, at least in the medication-assisted treatment field, how can we help level the playing field biochemically? Because again, just not to diverge, but that's all Suboxone does, right? Levels the playing field, speaks to that biochemical injury. So someone's not in craving, not in withdrawal, and ideally not using, so that they can engage in the hard work. And the hard work is exactly what my colleagues up here are saying. It's the trauma work. It's the digging in deep. It's the therapeutic alliance. Tonya and I were talking up here before this, and I didn't make this. I didn't come up with this saying. I think this is Gaber Mate or someone else. But the opposite of addiction is not sobriety. The opposite of addiction is often connection. And so as physicians, we are spoke on the wheel, at least in medicine. I'm going to tell you a little bit about what we've been doing at Front Range Clinic, is to try to give that opportunity, that life jacket, that life preserver, so we can speak to that biochemical injury, so that we can give folks the chance to get their head above water so that they can create these healing strategies, these healing tools, whether that's contingency management, CBT, whatever it is that needs to get done, and give them the opportunity to keep coming back. Because sadly, and I think we all know this, but this is the reality, is that relapse is not the exception. Relapse is often the rule. And it's hard to put our heads around that, especially my colleagues in medicine, because we like it to be very, A1C is this, and you do this, and you prescribe this medicine. It's messy. Doctors don't like that. So it's hard for folks to do that. So I'm just going to kind of segue into what we're doing at Front Range Clinic. And I'm going to be straight with you. From the very beginning, there is no indicated medicines for methamphetamine use disorder. There's nothing like Suboxone. There's no Vivitrol for alcohol. There's no methadone like for opiates. We don't have them. Are they in the pipeline? Hopefully. There's a vaccine in the pipeline for cocaine, which might have a crossover with methamphetamines. It's in trials in San Diego. It's pretty exciting. So in other words, if you took the drug, it wouldn't cross the blood-brain barrier. I'll be the first to give it to folks. I think there's a lot of exciting stuff out there. But in the meantime, what do we do? And so is there a role for the medical part of this? Is there a role for the physician? And I like to think yes. So what we try to do at Front Range Clinic, and I'll tell you in about a year if this is working or not, because then we'll have some more data set. We see about 1,000 to 1,200 people a week at Front Range Clinic. So hopefully we'll have some numbers to share with everybody. We start with behavioral. You have to, because that's where the data is. And we're science-driven in medicine, right? I don't believe in the word evidence-based. It's evidence-informed. I don't think anything's evidence-based. We're evidence-informed. That's the best you can do. And if you're dealing with things that have high mortality rates and high morbidity, you have to doing something is better than doing nothing, often. Not always, especially if you're prescribing medications. So we start with behavioral with folks. We do our best, but a lot of these folks that don't have the resources or that do have the resources that are not doing well or progressing to the goals that we have established as a team. When I mean team, the doctor, the behaviorist, and the patient, and the peer specialist. If we're not getting to those goals, should we look at medicines? Should we look at medicines potentially even off-label? I'm saying this on camera. That can be used to potentially level the playing field for folks. And the answer is yes, yes, and yes, of course. If you have an engaged patient, at least this is what we see in our clinics, and I think my colleagues here can speak to this. If someone wants help, we want to give them help. And if they want help and we give them that therapeutic safety to come back, to be there and not be judged if they're slipping, if they're still using, if they've disappeared for 2 weeks, 6 weeks, 12 weeks, if they've overdosed, if they've been incarcerated, but giving them that forum to come back and be safe, of course we should get into the ring with them and try to help and get in the trenches. Does that mean that we use medications off-label no matter what? No. We have some protocols, and we can go through those if people have questions after we kind of go through this with broad strokes. But we do. We try to treat the co-occurring mental health issue. We think about the physiology of what methamphetamines do for people. And can we use medicines that can help stabilize that? And there's about 5 or 6 off-label meds out there that have some data, not great data. And I have a good slide, which I could look at if you guys want to, that basically says, this isn't just me, this is the National Institute of Health, this is the American Society of Addiction Medicine, saying we got to do something. So we have some off-label medicines, things such as bupropion, Topamax, even naltrexone. And we have some other ones too we can talk about, that potentially give that person the bump so that they can maybe engage to talk to their counselor, to their peer specialist, to get involved in the contingency management in the group, which has the great data behind it. And then one of the main reasons I think that Leslie wanted me to come talk or be part of this panel was, and do we use stimulants? Do we use Ritalin and Adderall? Sounds scary. Because people could abuse those, right? They could snort them, they could inject them, they could combine them with methamphetamines. And most medical folks are scared to do that, right? Because there's no great data with it. And if they abuse the drug, they could potentially have really bad outcomes. So we're treading very slowly into this, but yes, at Front Range Clinic, we are dipping our feet into the water. And as I started doing this and talking to colleagues nationally and across the state, other folks are doing this too. Is it working? It's working with some people. And the folks that it doesn't work with, we quickly take that, we don't use that treatment. Because we always, no matter, every time we see a patient, it's, does this treatment's benefit outweigh its risk, even with Suboxone? We have to. So in certain patients, and I'll just give you kind of paint a picture of who would be a candidate for stimulants with a methamphetamine or stimulant use disorder. At our clinics, the folks that are good candidates for that are folks that have been using IV meth, folks that are dependent. So in other words, it's not I just do it on Saturdays and Wednesdays. The folks that actually could benefit from getting their hand held through a detox, which is not as severe as opiates, but still, it's no fun. It's no walk in the park. And so can we use these medicines to actually quell or potentially speak to this biochemical injury? And if the person's engaged and the person shows progress and they suddenly aren't using meth anymore, then we slowly taper them off. Has it worked? Yes. Has it not worked? Yes. But the reason I think I've been brought here is just to speak to that biochemical spoke on the wheel. And is there a role? And the answer is I think there is. And until we have done the studies and figured this out, which as many of you know, takes years and years and years until it gets into the mainstream, until an epidemic is over and done with sometimes, and people have lost their families. We're trying things, as we all are up here, because we don't have great treatments for this. We don't have the great tools that we've been getting from these other lectures where we're hearing, well, this is how you do this and this is how you do this. Methamphetamine use is on the upswing. It's gone up actually quasi-exponentially nationally. It's showing the same same curves as opiates did in the late 2000s and early 2010s. And the morbidity is real, and the mortality is real. So the idea that you can't die from stimulant use, that's not true. You can. You get arrhythmias, heart attacks, strokes, and it happens quickly. And we often see polysubstance use in the clinics, which is again more common than not. So it's rare that someone comes in and says, you know, I think my poison is just meth. Nah, the stuff that's been helping me, and you notice I say helping me, is probably sometimes all of the above. Whether it's opiates, whether it's alcohol, whether it's marijuana, whether it's meth. And yes, you've heard this message throughout today too. As providers, do we often figure out which shark is closest to the boat? And the answer is yes, we do that all the time. That's what you have to do in outpatient treatment. When you're in residential, when you're an inpatient, you have the luxury to say, all right, let's detox. Let's see where we're at now. But as we all know here and fellow providers, most of our patients can't get into the residential. Hopefully that's going to change in 2020 with Medicaid. We'll see. We'll all check back with each other in a year. So we have to meet people where they're at. And are we methodically, carefully starting to dip our feet into the water with certain medicines to help folks have an opportunity to create recovery? We are. And so we can get into that a little bit more. So I want to open this up to questions. You have three people up here that are representing three different modalities, and I know we're talking about stimulant use disorder, but I think I'm speaking for you guys. We can talk about whatever you guys want to talk about. Yes. Yeah. Without trying to cookie cutter the answer, what I would say to each case is individualized. Each case is dealt with doing our best to try to figure out what the response is with the doses we're giving to folks. People are seen at minimum weekly, at minimum. And some of our first things we're trying to do let me back up with that question a little bit. First thing is try to get the IV use out of there. So if we can, kind of like we were talking about in the other room, if you can get someone from drinking a handle of whiskey down to a beer, don't get me wrong, I get the progress. It would be good to have abstinence, but that's a success. So if we can decrease the chances of HIV and hepatitis C seroconversion by getting the needles out of there, that's a success. Doses, I think, are individualized. We do our best not to use the instant release medicines, even though, to be straight, they probably work the best if we could, and we have some patients we have. So for instance, your stimulants such as Ritalin, Adderall, things like that, they come in instant release. And if you look at the graphs, and I have a slide I could show you, but I'll just tell you, basically using methamphetamines and then using instant release Adderall and doing it multiple times a day, more than prescribed, it's basically the same thing. So we have to be careful on how we're prescribing it and what we're doing. So we do our best to try to use the controlled release medicines that give some of that dose over a period of 24 hours or 12 hours. So your Ritalin LAs and your Adderall XRs and things like that. We try. And then some patients we keep very close, and we see them a couple, 3 times a week even, and we're working together, and some of our great behaviorists are here from Front Range Clinic in the room, and they're working real close with them because, as we said, the data, the science drives the behavioral part of this. And we'll titrate up the medicine if we feel like it's working. If their use is going down, we will go to those doses. And this is all with this huge caveat that we have to be making progress, and the patient has to be an engaged individual to want to do this. And this isn't, sadly, and this is the medical legal part of this, is that the first sign of diversion or abuse, we have to be very, very careful. Diversion will usually stop, but are they going to abuse the medicines? Well, if they get the needles out of their arms and then you're able to help them manage how to take medicines, isn't that maybe that's normal progression? And this is where often I'm looking at Megan here in the audiences. I'll come out of a room and I'll say, Megan, what do you think? Because it's such a team sport. So is that speaking to that question? Okay, yeah. I mean, we're training the providers that you need to kind of, I hate to say it like this, earn the stimulant replacement candidate. The stimulant replacement candidate is somebody that has to go through, maybe jump through a couple hoops to get there. It's not out of the gates, hey, I hear you guys give Adderall for meth. Let me have Adderall.
I would have been first on your porch.
I mean, it has to be, and then there's cases, I mean, even a couple days ago, I got a call from down south, one of our clinics, and a provider saying, I just think this guy would really benefit from this out of the gates. And we went through the case, and she's seeing this person on Friday, and then we're going to see what happens. And there's a chance we stop doing this treatment next week. But there are cases that we maybe go out of the gates doing that, but those are rare. Yeah, we really try to get them into the matrix model, the contingency management, the CBT. And then I think, at least our protocols are, let's try some of the off-label tools first if we're going to go down the line of medications. But for the dependent IV user, it's a tough roller coaster to get off of still. And sometimes you're 6, 12, 18 weeks into treatment, and maybe you guys have seen this, and you're not making a lot of progress. And we want to help them. So I think there's a place for it. Yeah, I hope so. I hope so. I hope I'm giving you good data in a year. Yeah.
So are you asking between individual sessions and like how often they come in individually, and then how often they attend a case or a CM group or other groups? For me, it's whatever works for the person, right? They have to be able to say, this is who I am, or I don't know who the hell I am at this point because I've been so wrapped up in my addiction. So let's just get you in here. Let's get you stabilized. You get your physical. You do your intake. Let's see where you're at. And if they can come in and daily dose, it's phenomenal. And so what is the hook for that person? Some clients are like, I've talked myself out, like between rehab and residential and my family and blah, 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 all that stuff. And I don't want to do it anymore. So that's where I think the value of a contingency management group comes in, right? Or a group that is like, let's talk, but we're also going to have incorporated activities. And I think our clients, I do phototherapy, I do clay therapy, mask making, I do expressive writing. One, because clients really respond to that, and what they gain from that, what they communicate through a clay sculpture, I don't know if they'd actually be able to say those in words. So it's such a powerful influence to use those type of like art therapies. So for me, it's whatever works. You don't want to talk? Okay, can we sit for like 15 minutes and just see where you're at, and then I'll talk to you next week. So that's kind of where I'm at.
I would second what Wendy's saying, that I think it's very individualized. I mean, we'll see people like, for instance, let's say at a methadone clinic, and they need to stop the roller coaster. So they can do as much talk therapy as they want, but that first 2 weeks, they just need to stop doing heroin. And so in that place, the medicine is vital, right? And then there's folks that have come in and go, look, I've done all that stuff. You know, you can give me the Celexas and the Prozacs and the buprenorphins and all that stuff, and I'm telling you, I just need to do this trauma work. And sometimes they're in these guys' rooms more than mine. And I think that comes and goes. I mean, it changes maybe throughout the continuum of recovery. You know, so some folks will realize, they'll peel back the onion sometimes with cognitive behavioral therapy, and or something along those lines, and figure out, you know, maybe I would benefit from a mood stabilizer, or whether it's pharmaceutical or nutraceutical or something like that, to help rebalance the biochemistry a little bit. I mean, I'm jaded, so as a doc, you know, you know what Dr. Waller's saying is the stuff we see in these national conferences all the time, where we see these, it's like PET scan after PET scan after PET scan. So you're like, we get jaded, where we're just like, oh, you got to stabilize the biochemistry before you could do anything, you know. And these guys maybe have seen more the other way too. But I think your question is an important one, because I think it underscores and speaks to some of the message of this entire conference today, which is, we already get that most of the time we know there's biochemical changes, so let's address them. And we know that there's roots of this that medicines aren't going to help. And how do we integrate both of those right for people? And I think that's individualized.
I also think it's the same with support and support groups. People will make their own determination about what that needs to look like for them. I think that we've spent a lot of years, like with the 12-step programs, is saying, you know, go to 90 meetings in 90 days. And if people don't do that, sometimes they'll feel like a failure because I didn't get 90 meetings in 90 days. You know, for us with the peer coaching, a lot of what we do is say to people, what do you want to try? What do you think is going to be the solution? And, you know, I'll hear people say, Tonya, I'm not going to AA. And I'll say, oh, okay, I don't want to talk about what you're not going to do. Let's talk about what you are going to do. And, you know, they'll find different stuff. So, like, my peer coach and supervisor that I have, he does a lot of hiking, snowboarding. He does some 12-step groups. He does a lot of connection with people, hanging out with people in recovery. It's a connection of all this stuff. So I don't think that you can set a specific for every individual, but I think it's a personal choice.
Can I speak to one more thing to your question? I think it's important to define the goals. Someone said in the other room something about treatment to people or people to treatment. The idea that we all have this idea of, well, this is the way treatment should be, and the way I want this outcome to be is the way it should be. Versus meeting people, what are your goals? I mean, you could say the same thing with diabetes. What are your goals? Well, you know what? I don't want that really great control where I feel dizzy and lightheaded 80% of the time like my aunt did. I kind of would like to be a little on the sweeter side, and yes, I'm going to increase my risk of heart attack and stroke, but it's my life. Now, you know, as providers, you try to help folks navigate to different choices, but I think in in the addiction circles, it's pretty important to get to that place. Well, what is your goal? You know, so when people are not making progress, it's their progress that they're not making. It's not what your idea of the progress is. And it's hard because we all, and this has been said before, we're jaded, all of us, no matter how much we want to pretend like we're not, culturally and philosophically, on the way we look at drugs and alcohol and the way they're used. And so when you see the consequence of abuse or in addiction, where you see potentially families messed up and health and jobs and communities putting money into individuals and things like that, you can see how folks get jaded, right? But I think it is important to really establish, what is your goal? When I first meet a patient, it's one of the first things I say, what's your goals? You know, you'd be surprised. Some people say, you know, and speaking to what you were saying earlier, and I'm not saying that there's not some self-deception involved with this, but some people say, you know, I just need to stop doing heroin and meth, and we can talk about the pot later or something. Now, we can get into that. There's a whole other conversation of, you know, what cannabis does and potentially and things like that, and is it a tool or an anchor, and we can talk about all different ideas with that. But if that's that individual's goal, you are not making headway with that person if you keep bringing up the pot, you know? I mean, you got to think again which shark's closest to the boat, and what their goals are, going through, at least medically, going through the prism of what's going to hurt them, and then creating a treatment plan. And I think they can involve both medicines and behavioral in different percentages depending on the individual. So I would second that. I mean, that's anecdotal. So naltrexone is interesting medicine, and it's approved for alcohol and opiate use disorder. It goes to the mu receptor just like buprenorphine and methadone does. And it actually is what's called an antagonist, so it potentially blocks the effects of these drugs. And it makes sense physiologically that when we do give Vivitrol sometimes for stimulant use disorder. I mean, not right out of the gates writing for stimulant disorder, but we'll give naltrexone. It makes sense physiologically if you think about all drugs of potential abuse or misuse, all directly or indirectly get back to the dopamine system. So all of the drugs, from alcohol to marijuana to even behavioral compulsive type stuff, so gambling, pornography, things like that, they all indirectly or directly go to this limbic system and affect our dopamine secretion. So if we're actually speaking to that mesolimbic system, which controls that dopamine regulation or dysregulation, the idea that naltrexone could be novel in cases with stimulant use disorder, methamphetamine, absolutely. So the answer is yes. I've seen it anecdotally, and we'll often go there before we're going to go to your Adderalls and things like that. Yeah. That's not heroin. Yeah. Because that's the best one. Meth really goes up. And again, this is limited data. This is limited data, and this is off-label use for these things. But there is some data that topiramate or Topamax has had some help. Bupropion, we've seen some help. Naltrexone, I think, more blunts the dysregulated pathways and actually increases the dopamine. Those are your I think your major players if you're talking about dopamine. We can start talking about serotonin and norepinephrine and things like that. But those have been some players that have some evidence behind them, and we've seen in some cocaine trials. Some of the SSRIs and the SNRIs have been helpful. So your Celexas and your Lexapros and things along those lines. And I have to say this with a grain of salt. This is anecdotal. This is my experience. This is us what we're doing at these clinics as best we can, and trying to do a research, a meta-analysis of what the research is out there. But there is some data that it supports that. So serotonin, you're going to look at more of your SSRIs. And some folks, they really help level the playing field for, and some folks, they don't. And I think an underlying thing that we can speak to is the idea that many times when we're using drugs, we're trying to treat a co-occurring mental health issue. Mm-hmm. And so the idea is that if you can peel back the onion to kind of figure out what that is, and then potentially tailor a medicine that can at least level the playing field a little bit with that, it gives them a better shot. So let's say somebody has bipolar or a mood disorder, and you get them stabilized with a mood stabilizer or something along those lines that potentially helps a little bit. Do they do better with then their stimulant use disorder or opiate use disorder? And the answer is yes.
I personally had that experience. So when I was about 1.5 or 2 years into my recovery, I started having horrible panic attacks and anxiety attacks. And now I've always said the one emotion that I remember the most as a child was fear. So the question is, was it there before I started using drugs and alcohol? Or did it happen because of all that stimulant use, or did that help? I don't know. It doesn't matter. But the bottom line is that my life was really halting because I was afraid to leave the house. I was afraid to drive my car. And all this was happening, and I wasn't using drugs and alcohol. So for me to be able to address that issue in combination with the treatment I was getting for my substance use disorder was critically important. And it wasn't until I moved to out to Colorado, I talked to a doctor who was a friend of mine who's, because I'd grown up essentially in a abstinence hostile environment around 12-step and all that. And so I had this belief I should not be taking any medication. And finally he said to me, Tonya, you can only shoot so much meth into your central nervous system before it messes it up. So take the meds and be okay with what it does for you. And so I will openly disclose to you that I still take medication, prescribed antidepressants that help with the anxiety.
Well, that speaks to what you were saying.
Yeah.
Your question about, this ratio. And
She can't hear you.
The ratio is what works. What gets to your goals. And if you find out that over time that a little of this and a little of that, and keeping in with the behavioral and keeping in with the going to AA, if that's what works, then that is your treatment plan. Mm-hmm. And if we have to make an amendment tomorrow, then we do. We're done. So we're available a little bit afterwards. Thank you.